Thank you, Dr. Matthew Fay, a GP from Bradford, Yorkshire, and trustee of the AF Association and also Arrhythmia Alliance medical advisor. Thank you for joining us to answer questions on atrial fibrillation.
Pleasure, Trudie.
AF medication treatments and device treatments. What is the difference between rate control and rhythm control for AF?
So, atrial fibrillation tends to run the heart a little bit fast. So, somebody who's in atrial fibrillation will generally have a faster heart rate than somebody who isn't. Now, that may be because the heart's a little bit less efficient in atrial fibrillation, so it has to go a little bit faster to do the same amount of work. Occasionally, it goes too fast. So you could take your pulse and you could find that you have a heart rate of 120, 130 beats per minute just sitting still. Now, in those cases, we can't allow the heart to run that fast all the time. So we'll need to bring down the heart rate. If you have no symptoms and your heart rate is around 90 to 100 beats per minute, then we might not need to treat that at all. So we don't need rate or rhythm treatment. If you do have symptoms and your heart is running fast, the first thing that we would suggest is that we slow it down, bring it down to that 90 beats, around about 90 beats per minute, to see if we can control your symptoms. If that works, that's rate management, because we've controlled the symptoms of your AF purely by controlling the rate that the heart goes. If that doesn't work, and you're still feeling the palpitations, you're still feeling the breathlessness, you're still feeling that fatigue that can come with AF, then we need to consider getting the heart back into normal rhythm, shocking it back, or using other procedures to make the heart return to sinus rhythm. And that would be regarded as a rhythm management. And so that can be done with medication, it can be done with an intervention called ablation, but it requires the heart to be changed or medicated to maintain the normal rhythm.
So some people with AF are prescribed beta blockers. What do the beta blockers do? And one person wants to know, can they still drink alcohol if they are prescribed beta blockers?
So beta blockers are, an easy way to consider a beta blocker is an anti-adrenaline. So if you think about everything that adrenaline does to you, it makes you feel bouncy, makes you feel very alert, makes your heart race. A beta blocker does the opposite. So a beta blocker will slow the heart rate down. Unfortunately, in some people, it can also therefore make them feel a bit sluggish, because adrenaline makes us feel very active. So beta blockers slow the heart by being an anti-adrenaline, but sometimes give us side effects in the fact that they make us feel tired and sluggish. And so we might need to think of an alternative. Can you drink with them? Of course, alcohol in moderation is part of the social part of our lives, and we should always enjoy alcohol in moderation, as recommended by your own clinician or the public health department.
One patient has asthma and that they find that beta blockers affect their breathing. What is an alternative to beta blockers?
So beta blockers are the exact opposite of the Ventolin inhaler that many people use for their asthma. So some people with asthma, particularly if they need to use their Ventolin, their salbutamol quite a lot, may find that the beta blocker reduces its effects or actually makes them feel breathless when they're not using it. So we need to think of another way forward. And there's a family of medication called the rate-limiting calcium channel antagonists. The best one, the one that we best know, is diltiazem. And we could recommend the use of diltiazem, which works in a similar way to slow the heart rate, but without that beta blocking, that anti-adrenaline effect that can cause problems in asthma and also in those people with fatigue on beta blockers.
One patient's been prescribed Flecainide by their doctor, but have been told that it should be initiated in hospital. What does Flecainide do, and do we need to go into hospital for it to be initiated?
So Flecainide is one of the drugs that we would call an antiarrhythmic. It's one of these drugs that try to keep the heart in normal rhythm. Now, it can be a very effective medication in atrial fibrillation. So if you have atrial fibrillation that comes and goes, that is to say paroxysmal atrial fibrillation, then Flecainide can stop the number of episodes that you have. Unfortunately, AF has a closely related heart rhythm problem called atrial flutter. And sometimes they can feel the same, and sometimes they can almost look the same on an ECG to the uninitiated eye. Now, Flecainide is not a good drug in atrial flutter. So a lot of clinicians would say the safest way to make sure you're going to be okay with your Flecainide is to have it initiated in hospital. Not all clinicians do that. Some clinicians would suggest that we can use Flecainide with a beta blocker and initiate it in the community. But if we don't know exactly that you have paroxysmal atrial fibrillation and we think it may have other components, then by far the safest thing to do is to start that drug in a hospital setting.
Dr. Fay, as a GP, when would you refer a patient to a consultant in a hospital with AF? When should they be managed in primary care? When should they be referred on to secondary or tertiary care?
So many patients with AF are identified in primary care. They come because they've got palpitations, they may have noticed breathlessness, and when we examine them, we may notice the irregular pulse. Some patients don't even know they have AF, and we spot the irregular pulse while we're checking their blood pressure. So a lot of AF is managed in primary care. Primary care's major role is to do that stroke assessment. That should be done as soon as somebody's identified as being in AF, and then if appropriate, because their risk is high, then an anticoagulant should be recommended, and hopefully the patient will accept that. If the patient's symptomatic, then many GPs may refer to their secondary care colleagues, my patient's symptomatic with their AF, would you see advice please? However, increasingly, we're seeing that GPs will try that rate management. So they will initiate the beta blocker or the diltiazem, slow the heart down, and if their patient is no longer symptomatic, they may choose, with the patient's consent, not to refer them on to specialist care, because there's little that the specialist would need to do. But if a patient is symptomatic with AF and their GP is not referring them on, then they should really insist that they should see a specialist, preferably a rhythm specialist, an EP consultant, to discuss their AF further management, because we can do a lot to help patients who are symptomatic of their AF, but it's out with the remit of the general practitioner.
And what can the patient do to help better manage their AF? What lifestyle changes might be needed?
So a lot of what we've talked about is medication based, but we know that the heart likes activity. And so a patient should exercise, not too much. We know that the triathletes and those people who do extreme cardiovascular exercise can have problems as well, but we should always exercise with our AF. Our heart likes to live in a reasonable body shape. So if we feel that we've got a little bit of extra weight, particularly if that weight is around the middle, then reducing your weight will always help with atrial fibrillation. And also, we need to be very conscious of those people who are snorers. Some people who are snorers, particularly the house shaking snorer, they may actually have a condition called sleep apnea. And that might need to be identified, because we know that if we control people with sleep apnea, then their episodes of atrial fibrillation are reduced. One of the biggest treatments for sleep apnea is to lose weight, and unfortunately also watch the alcohol you consume. So there are lifestyle changes that you can make, even if the issue might be something a little bit more fundamental.
Dr. Fay, thank you so much. That will be a lot of reassurance and information for patients with AF and their loved ones. Thank you.
Thank you very much, Trudie.